Good evening, everybody. It is a great honor for us to continue our ACOD continuous medical education, and it is I am Abdulsalam Ismail, the head of clinical oncology department at Alexandria University, and it is my honor to share this meeting. I have to introduce Professor Dr. Neil Ramos, the head of thoracic oncology at Munich. Germany, and I am sure that we will have a very fruitful scientific meeting today with our speakers, Dr. Gamal Hosseini and Dr. Walid Arafat, and I am sure that we will have a lot of interaction in a very hot topic in non-small cell lung cancer. Dr. Neil, please.
Yeah, thank you very much, Professor Attia, for the very nice introduction, and thank you very much for the nice invitation. It's a great pleasure to be here. It would be even better if I was there in person, but well, we all know the reason. But nevertheless, it's a great honor to participate here and share my my thoughts on current developments in non-small cell lung cancer and small cell lung cancer. And I will be very happy if you can raise questions, as many if you like. But nevertheless, I will start now. First of all, on focusing on non-small cell lung cancer. So I was just want to give you a brief impression how much is really ongoing in thoracic oncology. Non-small cell lung cancer, we all know 80% of all lung cancers will be non-small cell lung cancers. And with those, we have a huge separation between those where we can give targeted therapy and those where we cannot. So it's really important that in stage 4 disease, if we have only systemic therapy left, that we do a comprehensive molecular testing, because about 20% of non-small cell lung cancers will harbor targetable alterations. And if this is a non-smoker, the chance is even higher than 50%. In particular, non-smokers or fewer smokers. The rest is only can receive chemotherapy with or without immunotherapy, but this field again is also in the change, and I will come to this a little bit later. But most of all, it's important that we do molecular testing up front, and this is also stressed by the recent NCCN guidelines that after the diagnosis is established, the histologic subtype, then in particular non-squamous non-small cell lung cancer, but even squamous cell carcinoma, both tumors should be tested for molecular alterations. The chance that we find alterations in small cell carcinoma is rather small, but nevertheless it's being recommended. We do that as well. But of course, most important is that they do it in non-squamous, non-small cell lung cancer. So what does it mean, molecular testing? Well, it depends on the therapeutics which we have available for treating patients. And so far we have agents approved, at least by EMA and FDA, for EGFR mutations, ALK alterations, ROS, BRAF, NTRK, and RET. FDA also has MET exon 14 skipping mutations. And important is that PD-L1 testing should also be done in all tumors. But if we find a targetable alteration, then it really this patient should not go for therapy, but this patient should go for targeted therapy. How can we do biomarker testing? Well, we have certain technologies available. We can do an allele-specific PCR. We can do a classic style FISH for ALK and ROS and RET. We can do conventional sequencing, which is, of course, more comprehensive view, but I think for most cases, it's rather recommended to do NGS, which means massively parallel sequencing, because it saves time, it saves resources, it saves money, because it's much cheaper to do an NGS for 10 alterations, let's say, in comparison to do one after another, which is probably more expensive and also more tissue consuming. What about PD-L1 assessment? We do know that it's not that easy. It really depends what do we want to test. There are several scores out there, the so-called TPS, the tumor proportional score. That score is only looking for PD-L1 staining of tumor cells. The very opposite is the immune cell score on the very right-hand side, where we only look for the PD-L1 staining for immune cells, regardless of the intensity. And then, of course, the combination of both the TPS and ICS together, which is the combined proportional score, which looks at PD-L1 expression for both tumor and immune cells. And normally, the CPS is done all collectively, so not separately, but collectively. Which score is used depends on the antibody which has been investigated in clinical studies, because every antibody has basically been tested with a special antibody for PD-L1 testing. Nevertheless, at least in Europe, we can use any antibody, and depending on the result, we can use any drug which is available and approved. That means, even though, for example, the TPS score for a certain antibody 22C3 has been analyzed and developed with pembrolizumab, we can use atezolizumab or nivolumab or whatever, regardless of the antibody which we are using in our hospital. And in fact, we only use one antibody and not 4 of them, for example, because we have at least 4 different drugs which can be used in the treatment of non-small cell lung cancer. I think this is definitely a wise thing to do. We should keep in mind that the scoring system is really antibody specific a little bit, and every antibody has some strengths and weaknesses. But in total, if you have a PD-L1 result, you can use any antibody you want. So, for example, atezolizumab, the PD-L1 antibody which we are talking about today in the majority of the time, I think, this has been developed with a special antibody looking at both tumor cells and IC cells, immune cells. So it's a little bit like the combined proportional score, but this antibody looks specific only at tumor cells, and then in a second step only at immune cells. And the scoring system is that for tumor cells, we have, for the high expressors, 50% is the threshold, for the low expressors 5%, very low expressors 1%, and 0 is less than 1% for the tumor cells. The IC score, the immune cell score, looks at 10% at the high expressors, 5 and 1%. And you may think that, yes, whatever, I mean, it doesn't really depend which cells you measure. Actually, it does, because we do see in some clinical studies here on the right-hand side, this is data from the second-line study, where we can see that the high expressors have either high tumor cell expression or immune cell expression. And we do know that those with a high immune cell score will also benefit from the drug, but this scoring is normally not being done with other antibodies except SP142, which is actually the antibody which has been tested in combination with atezolizumab. So yes, it's a little bit special, But we should keep in mind that the SP142 antibody, this is the antibody where all atezolizumab studies have been developed with, is looking at both tumor cells and immune cells. What about molecular alterations? Well, back to the alterations. This was just pillar 1 before. The alterations is that we know that we have some alterations where we can use drugs against with, like EGFR, ALK, and ROS, and so on. But they are much more in development, like HER2, or like MEK1, or even KRAS, at least some certain subtypes of KRAS. So the picture is getting broader and broader. So we have much more possibilities to treat molecular alterations specifically. And this is very important because we can get much better data and overall survival if we can hit the right target with the right drug. Immunotherapy may work in some situations, but not in all of them, and also in some molecular alterations, but again, not in all of them. So it really depends on the alteration. But the most important message here is you need to look for testing, and if there is some finding with a druggable alteration, then this is the way to go. And with this, I would like to hand over to my colleague who is focusing on ALK-positive non-small cell lung cancer. This is a perfect example how the finding of a molecular alteration like ALK really results in a much better clinical benefit if we use the right drug.
Okay, thank you. Thank you. I think we can, Dr. Gamal.
Yes.
Yeah, you can start now.
Yes, good evening, everybody. Very happy to be with you this evening. I would like to thank Roche Group for giving me this opportunity to share with you in this very important event. I'll talk about the updates in ALK-positive metastatic non-small cell lung cancer. These are my disclosures. About 60% of patients with metastatic non-small cell lung cancer don't have actionable driver alteration detected. The most alteration seen in KRAS, 25%, followed by EGFR in about 15%. In some populations, sometimes it's reaching up to 20 or 25, followed by ALK in 5% of the cases, MET in 3%, HER2 2%, BRAF 2%, RET 1 to 2%, and ROS 1 to 2%. And these are the target agent approved in the till 2021. In summary, ALK-positive non-small cell lung cancer is a rearrangement of the gene. An ALK-positive non-small cell lung cancer, rearrangement of ALK within the chromosome result in the expression of an oncogenic fusion protein. ALK fusion proteins activate signaling cascades in the absence of ligand binding, which promote tumor growth. ALK inhibitors promote cancer cell death by restoring apoptosis and inhibiting tumor cell growth and proliferation. ALK fusion protein have been detected in a variety of hematological and solid tumor types, including lymphoma, inflammatory myofibroblastic tumors, and non-small cell lung cancer and glioblastoma. The prevalence of ALK fusion protein varies according to tumor type. Up to 50% of patients with anaplastic large cell lymphoma are ALK fusion positive. ALK rearrangement occur in only 5% of patients with advanced non-small cell lung cancer. Patients with advanced ALK-positive non-small cell lung cancer are typically non-smokers and have specific histology. 75% of the patients have never smoked, and over 90% of patients with ALK non-small cell lung cancer have adenocarcinoma histology. The typical characteristics of patients with ALK-positive non-small cell lung cancer: younger patient, median age 52 years versus to 71 years for lung cancer in general, never or light smokers, adenocarcinoma histology, advanced disease and presentation such as pleural myocardial effusion, multiple lesion sites, and CNS metastasis. There are 5 approved ALK inhibitors for first-line treatment of advanced ALK-positive non-small cell lung cancer. The first one approved was crizotinib Zarkuri in August 2011, ceritinib Zycadia in May 2017, alketinib in November 2017, brigatinib in May 2012, and last month, loratinib was approved as a first-line treatment in ALK-positive non-small cell lung cancer. Regarding the progression-free survival of the first-line ALK inhibitors, crizotinib based on profile trial give about 11 months progression-free survival. Ceritinib in ASCENT trial give about 16.6 months as a progression-free survival. Alectinib gives the highest progression-free survival, 34.8. Brigatinib gives 29.4, and loratinib not yet estimatable. This is a study which led to the approval of crizotinib as a first-line treatment, ALK-positive non-small cell lung cancer. This is a profile 10 to 14. This is a patient with ALK-positive disease according to FISH, locally advanced or metastatic non-small cell lung cancer, no prior platinum-based chemotherapy regimen, stable or treated brain metastasis, ECOG 0 to 2. Patient were randomized 1-to-1 to crizotinib or pemetrexed cisplatin or pemetrexed carboplatin. And as you see here, the efficacy of the drugs, the progression-free survival, the median progression-free survival was 10.9 months with crizotinib compared to 7 months only with chemotherapy. And the major side effect from the crizotinib was patient disorder, diarrhea, edema, vomiting, and constipation. So with crizotinib, we got a progression-free survival of 10.7 compared to 7 months only median progression-free survival with chemotherapy. ALEX is a randomized phase 3 open-label study of alectinib versus crizotinib in treatment-naive advanced ALK-positive non-small cell lung cancer. Patient with stage 3B and 4 non-small cell lung cancer, ALK-positive according to here immunohistochemistry, treatment-naive with ECOG 0 to 2. Study including 303 patients, randomized 1-to-1 to alectinib 600 milligram BID compared to crizotinib 250 milligram BID. As you see here, the median progression-free survival with alectinib was 34.8 months compared to 10.9 months only with crizotinib. And this is the final mature progression-free survival achieved. So alectinib demonstrated more than 3 longer systemic efficacy benefits than crizotinib. The progression-free survival benefit was consistent in alectinib-treated patients, irrespective of CNS metastasis at baseline in the ALEX trial. So patient with CNS metastasis in baseline is this figure. There is always improvement in the progression-free survival at 1 year, 2 years, until 4 years in favor of alectinib compared to crizotinib. And the same is true in patients without CNS metastasis at baseline. The progression-free survival benefit with alectinib versus crizotinib in ALEX trial was consistent across a number of patient subgroups, including age, sex, race, smoking status, ECOG performance status, CN metastatic as baseline, and the brain irradiation. Patient treated with alectinib in ALEX trial demonstrated high and durable systemic response. The overall response rate was about 83% versus 75% with acod2021. So in ALEX, 83% of patients responded to treatment with alectinib with a durable response. In ALEX trial, overall survival and trending activity for alectinib versus acod2021, the median progression-free survival was 57.4 with acod2021 and non-estimable in the alectinib. Overall survival data remain immature at 5-year time point, with about 37% of events reported in the intention to treat population. Percentage of death was 34% in alectinib compared to 41% in acod2021. ALEX trial, patients receiving alectinib showed a clinically meaningful improvement in overall survival rate versus acod2021 as the 5-year time points. ALEX is the first global randomized study of a next generation TKI to demonstrate a clinically meaningful improvement in overall survival. ALEX trial also, alectinib delays the time until CNS progression versus acod2021 in the ITT populations. At 1 year, the progression in the CNS was 41.4% in acod2021 compared to 9.4% only with alectinib. Also, alectinib prolongs the time until development of new CNS metastasis and the progression of existing CN metastasis. In ALEX trials, also a higher proportion of patients with CN metastasis at baseline demonstrated intracranial responses with alectinib compared to acod2021. The CNS overall response rate was 81% versus 50% only with acod2021, and in patients with measurable or non-measurable disease, the CNS overall response rate was about 60% with alectinib compared to 86% with acod2021. Alectinib demonstrated a favorable safety profile versus acod2021, and no new safety signals were observed after long-term follow-up up to 5 years. The median treatment duration of alectinib was 17.9 compared to 10.7 months only in acod2021. The serious adverse event was nearly the same in both drugs, and also grade to 35% was nearly the same between the two drugs, with no major difference between the two drugs. In ALEX trial for adverse event, where the rate differed by more than or equal to 10% between treatment arms, the majority occurred at a higher frequency with acod2021. Adverse events more frequently observed with acod2021 are nausea, diarrhea, vomiting, ALT, and peripheral edema. However, with alectinib, the most common side effects were anemia, myalgia, and blood bilirubin increased. Consistent results in 3 phase 3 trials support alectinib as a preferred first-line treatment option and standard of care for patients with previously untreated advanced ALK-positive non-small cell lung cancer. Regarding the systemic efficacy, alectinib demonstrated consistent, significant improvement in median progression-free survival versus acod2021, irrespective of CNS metastasis at baseline. As regarding the CNS efficacy, alectinib consistently prolonged time to CNS progression compared with risatonib and demonstrated high intracranial response rate. And regarding the favorable safety and tolerability profile, alectinib is well tolerated with a well-characterized safety profile that is maintained with long-term use. The NCCN guidelines recommend alectinib as a preferred first-line therapy option, category 1, in ALK-positive non-small cell lung cancer, and the ESMO clinical practice guidelines also give alectinib the highest level of recommendation and the highest magnitude of clinical benefit scale of 4. Regarding the progression-free survival benefit for the first-line ALK inhibitors, as you see here in these figures, with rituximab 10.9 months, with ceritinib 16.6 months, alectinib, the highest is 34.8 months, brigatinib 29.4 months, and with loritinib non-estimable. So alectinib is recommended as a preferred first-line treatment and standard of care for patients with advanced ALK-positive non-small cell lung cancer in both the CNN and ESMO guidelines, with the longest median progression-free survival so far. This summarizes the most common adverse events of the interest in the first-line ALK inhibitors. Regarding the alectinib, the most common is constipation, anemia, and fatigue. For ceritinib, diarrhea, nausea, vomiting, and ALT increase. For crizotinib, patient disorders, diarrhea, edema, and vomiting. And for brigatinib, diarrhea, CPK increase of an early onset of interstitial lung disease and pneumonitis. And this is the ESMO guidelines, putting alectinib is the category number 1. And also in the NCCN guidelines, the last version, putting alectinib as a preferred treatment, and category 1 is the treatment of first line in metastatic non-small cell lung cancer. By this, I will end my talk, and thank you very much for listening.
Okay, thank you very much, Professor Gamal, for this elegant presentation. And one question before giving the floor again to Dr. Niels, and the question is for Dr. Gamal and Dr. Niels both together. Can you hear me well?
Yes.
Okay. Regarding the use of alectinib in the adjuvant setting, I know that it's not in the guidelines, but I know that there is a large trial going on, and some of our colleagues in Egypt are participating in. Do we have any preliminary data of the use of alectinib in ALK-positive patients in the adjuvant setting?
You go ahead.
Well, no, so far, because first of all, we don't test for ALK in adjuvant setting because we don't get it refunded. And second, there is no approval of alectinib in the adjuvant setting. I think it makes sense, in particular, once we have seen now the osimertinib data, I think it makes sense that we should test also early stages for molecular alterations. But so far, there's no approval, and therefore we don't test and we don't treat patients. We have no data so far convincingly demonstrating the use of, let's say, 3 years of treatment resulting in overall survival benefit. Even not osimertinib, we're still waiting for this data.
Okay, thank you. Thank you so much. Any questions from the audience? Okay, in that case, I will kindly ask Dr. Niels to resume and go for the rest of the presentation, please. Dr.
Yes, thank you very much. Yes, so we are here again, looking first of all, non-squamous, non-small cell lung cancer, but also squamous actually could be tested. Metastatic disease, they should be tested first for molecular alteration because, as we've just seen, a 5-year overall survival rate, median, more than 5 years is something which we cannot yield with any other therapy so far. So this is just really outstanding data. I think this is really a landmark trial, the ALEX trial, demonstrating how efficacious these agents are for treating molecular alterations. But anyway, the majority of patients won't have an addressable driver mutation, in particular heavy smokers. And for those patients,
sorry for interrupting, but we can't see your screen actually. Can you reshare it again?
Oops, sorry.
Thank you.
Yes, sure. There we go. Can you see it now?
Yes.
Wonderful.
Yes, we can see it very well. Okay.
So again, molecular testing is really important upfront, but the majority won't have an addressable driver mutation. And for those patients, we only had chemotherapy until some years ago. But then we have now the development of checkpoint inhibitors, which means immunotherapy. So we use the patient's immune system to really treat the cancer by itself. And there are several checkpoints, we all know that, and we can really we can enhance a particular checkpoint, the PD-1, PD-L1 axis, program death, that is what PD-L1 stands for. And this program death ligand, program death axis, can be enhanced by particular antibodies. So we have now a completely new scheme. So after the molecular testing, we have based on the PD-L1 expression testing, which should also be done upfront. We do it in every patient. We can divide our patients in the PD-L1 negatives or nearly negatives, less than 1% of the expression. And now I'm just using all kinds of scores. So regardless of you have TPS, CPS, or whatever score, less than 1% means this patient has nearly no PD-L1 expression. We know that there is some heterogeneity, but this is the data we have so far. We have the intermediate expression, 1 to 49%, and those with at least 50% of PD-L1 expression, these are the so-called high expressors. And so far we have several options, and the question is not to combine immunotherapy with chemotherapy. The question is, should we combine chemotherapy with immune therapy? So immunotherapy, this is something when we can do it, we should do it, regardless of the PD-L1 status. The question is only, can we do it in monotherapy or in combination with chemotherapy or in combination with chemotherapy and another IO agent? These are at least the approvals so far. In America, we have also only IO approval without chemotherapy, but not in Europe. So, for example, for the high expressors, there are several studies out there which have consistently demonstrated the superiority of a treatment of PD-1 or PD-L1 antibodies without chemotherapy in comparison with platinum-based chemotherapy, first line. So like here, the acod2021 trial, significant improvement of the monotherapy with PD-1 inhibitor pembrolizumab. In the acod42, the same story, just a different trial. The Impower 110 study, again, the high expressors here looking at tumor cells and or immune cells. Again, significant superiority with the checkpoint inhibitor in comparison to chemotherapy. And very recently, the Impower Lung 1 study, here looking for cemiplimab in comparison with chemotherapy, same result. So this is really consistent, and this is for those with a high PD-L1 expression, we can and we should use immunotherapy. The Impower 110 study, for example, was one of those trials looking for every 3 weeks atezolizumab in a fixed dosage, 1,200 milligrams, in comparison with chemotherapy, with platinum-based chemotherapy, either in combination with pemetrexed for non-squamous or with gemcitabine for squamous histology. And then, of course, the immunotherapy is ongoing every 3 weeks until progressive disease or loss of clinical benefit or not tolerable anymore. And for the chemotherapy arm, we could use the pemetrexed maintenance for non-squamous, non-small cell lung cancer, but this was up to the investigator. And there was a mandatory PD-L1 testing and a stratification based on sex, ECOG, and PD-L1 expression. Why? Because there was a hierarchical testing plan looking first in only the high expressors for tumor cell or immune cell expression of PD-L1, overall survival, and then looking also in intermediate or low intermediate expression in combination with high expression. So this was the statistical plan. This is important to understand the results of the study. What about the PD-L1 testing distribution? We know that about a third of every patient will have a high expression of PD-L1 here in tumor cell or immune cells. We see that the distribution between chemotherapy and the immune therapy was very similar. This is the overall survival, the primary endpoint of the high expressors, demonstrating a significant and I think a very clinically relevant improvement of overall survival for atezolizumab in comparison with platinum-based combination therapy in first-line non-small cell lung cancer. And the median, of course, was significantly improved, 20.2 months versus 13.1 month, hazard ratio of 0.59. But most importantly, there is a rate of patients with long-term benefit. This is something which we don't see with chemotherapy only in general. We do see some patients having a long-term benefit in the chemotherapy only arm here as well, but this is because of crossovers to immunocheckpoints after progression in first line, now receiving for immunotherapy in second line. So this rate of patients with long-term benefit, long-term survival with checkpoint inhibitors, this is something which is typical for immune therapy, and this is now the reason why we give immunotherapy upfront. There was an updated analysis seen at World Lung Cancer Congress in 2020, which was taking place in January this year. And here the updated analysis confirmed the arm of atezolizumab. The median was still 20.2 months. The comparator arm has somewhat improved. Now the median overall survival was 14.7. Earlier it was 13.1 months in the chemotherapy only arm. But again, there's some crossover in the chemotherapy group, of course, and therefore the hazard ratio is not as high anymore as it used to be. But nevertheless, this is really confirmative regarding the atezolizumab arm, and therefore the message is still the same. Atezolizumab is a preferred choice for high expressors for non-small cell lung cancers. What about subgroup analysis? We see that basically all kinds of patients seem to benefit from the immunotherapy. For very elderly patients, it's difficult to tell because of only 22 patients were in this group. Therefore, no data for really drawing any conclusions here. Male, female, and so on. And even squamous or non-squamous histology benefited from the same extent. And also, ECOG performance status was no major factor. In fact, in my clinics, I like using, even for those patients with ECOG performance status 1+, let's say like this, the immunotherapy, because it's much better tolerable as patients with chemotherapy. What about progression-free survival? Same picture here. Significant and clinically relevant improvement of progression-free survival. And here again, you see the patient with long-term benefit, long-term treatment with atezolizumab. And of course, this result was statistically significant. Hazard ratio of 0.63. This is a range of hazard ratios which we were not used to see when we compared chemotherapy versus another chemotherapy. What about response rate? Even this response rate was improved by only monotherapy with atezolizumab compared to combination chemotherapy with arm B here, 38.3% versus 28.6%. And we can see here that in patients with intermediate or low intermediate expression, there is similar response rates as compared to the chemotherapy arm, and there was also no overall survival benefit, which is actually also very much aligned with other studies like Keynote-42. Safety. So far, it looks that there's no huge difference. The adverse events were rather similar, 90.2% versus 94.7%. But I would like to stress that indeed there is a big difference because the grade 3, grade 4 events is much less fatigue, no need for weekly blood testing, and there is of course some certain there are some certain side effects. We all know that with immunotherapy that there is so-called immune-related adverse events, but we can see here the majority of those side effects which really impairs patients like anemia, nausea, neutropenia, constipation, thrombocytopenia, vomiting. This is much less as compared to the chemotherapy here in red. Those patients which were more frequent with atezolizumab, like pruritus, hypothyroidism, increased liver enzymes, this is typical for immune cell related adverse events, and normally this is a very low grade and easy to handle with. But we have to mention that yes, there are some larger and more severe immune-related adverse events like rash, hepatitis, pneumonitis, but only very few patients will experience that. But nevertheless, we should, as clinicians and physicians, we should be aware of those side effects, and we need to act rapidly to treat those patients, to stop the treatment with immunotherapy, to treat them with steroids and others drugs is necessary. And then we can easily handle, in general, we can easily handle those severe side effects as well. Some side effects like hypothyroidism and so on, even hypothyroidism. This is something which we notice when we do the lab checking, but we continue the immunotherapy because this is easy to substitute and nothing really to concern. So consequently, this study has been published in the New England Journal of Medicine, and it's being an approved drug for first-line treatment for high PD-L1 expression, at least in the FDA. In the US. In Europe, it's being announced that it will happen rather soon. But so far, at least to my information, it's not approved yet, but I think this is only a question of a couple of weeks. There are other trials who investigated the same topic. Here, pembrolizumab, PD-1, antibody versus chemotherapy, high expressors here now using the TPS score, but you see the results is very similar. Significant improvement of overall survival and progression-free survival. And this trial was read out a little bit earlier, and therefore we have now here a 5-year overall survival. Again, this is patients without molecular alterations, and you see that there is a chance of 31.9% of hitting 5-year survival with the treatment of a checkpoint inhibitor upfront. In Impower 110, since the Keynote 24 and 42 studies used a different antibody, here the 22C3 antibody, and therefore in the Impower 110 study, the patients were also being retested using a different antibody. SP142 was the antibody used regularly for the study, and that's what the certification was done with. But it was also done with the 22C3 antibody and this SP263 antibody. This is the antibody which was developed in combination with durvalumab. And you can see that basically, regardless of the antibody you use, you find a little bit different patients which were positive, but nevertheless, all results looking basically confirming the superiority of the checkpoint inhibitor treatment in comparison to chemotherapy. And this is a patient of us. We did participate in the Impower 110 study. This is a male, or was a male patient of 67 years of age when we diagnosed him in 2017, former smoker. He had a TDF1 positive lung adenocarcinoma. Molecular testing was negative. PD-L1 was positive. We didn't know the result because this was not communicated to us, but we did include this patient to the Impower 110 study. And he had T4N1M1 stage, several brain metastases, here indicated with the red arrows. And we did a stereotactic irradiation of the large brain mets, which we could see. There were some tiny ones which we could not irradiate. And this patient really used to have a rather poor prognosis with chemotherapy only. Huge tumor in the left upper lobe, also invading the mediastinum. And then we put him in the Impower 110 study. He was treated with atezolizumab. Here, this is the initial CT scan, and this is only 2 months later. You can see that the tumor masses have shrunk tremendously. And actually, this patient is still receiving atezolizumab, and there's nearly no sign of any tumor, since we cannot really distinguish between some residual tumor tissue or no tissue. We still see that this is a minor enhancement of unknown significance. This is the picture which we see since at least 1.5 years or so. We continue atezolizumab. The patient is doing very well. He has no side effects so far. He's living a normal life. And therefore, this patient is feeling fine with stage 4 non-small cell lung cancer and brain mets. And actually, the brain mets, they have gone as well. And therefore, yes, this is something which we have not seen when we had only chemotherapy. So this is definitely something which is of huge benefit for our clinical practice. So the inclusions for the Impower 110 study is the atezolizumab monotherapy showed statistically significant and clinically meaningful overall survival improvement in the high expressor population versus chemotherapy and platinum base here. The hazard ratio here was 0.59. The updated was a little bit less. In the TC and IC3 wild-type population, atezolizumab showed also a meaningful improvement of progression-free survival over response rate and duration of response versus chemotherapy. Safety was consistent with prior observations, no unexpected safety signals, and to my opinion, a very tolerable therapy for most of the patients. And therefore, it represents a very promising first-line treatment option in patients with high PD-L1 expression. And here, I guess I stop before I come to the combination with chemotherapy, one last look at the NCCN guidelines here as well. Atezolizumab, like pembrolizumab or also cemiplimab, is being recommended as first-line treatment for high expressive of PD-1 expression. And in FDA, it's also approved for median expression, but not in Europe at least. And therefore, I think it underlines how important it is to do not only a molecular testing, but also a PD-1 expression testing. So here I stop now, and I will happy to address questions if there are any.
Yeah, actually, thank you very much for this part. Actually, very comprehensive, informative. Thank you, Dr. Niels. And I would like to ask any of the audience if they have any question or comments they would like to add.
Yeah,
Okay.
Dr. Neil, I would like to ask you if you have a patient who is presented with PD-L1 expression of 50 and by DACO, are you going to repeat it with SP142?
No.
No, you are satisfied with this 50.
Yeah, well, we have a in Germany we are participating in a special quality setup here. We compare our PD-1 testing with other labs, and we confirm that we have a good and reliable result. We should keep in mind that the PD-1 expression is heterogeneous, and so if we have a patient like with 40% of PD-1 expression, we don't do a retesting with a different antibody. We would probably start with immunotherapy in combination with chemotherapy then, and then at least after 4 cycles, we finish chemotherapy and continue with immunotherapy. This combination works in all, works independently of the PD-1 expression, and I don't think there is a need of really hitting the PD-1 expression too much.
Okay. If a patient
we have a
first line, go ahead. If a patient receive a first line immuno, what you are going to offer him in second line?
Good question. Very good question. Probably the majority will try. We will try platinum-based chemotherapy, but we may. It really depends on what kind of progression it really is. We may consider of adding chemotherapy, but this is nothing which we have looked for in clinical trials yet. But maybe some patients may benefit from adding chemotherapy and continuing with immunotherapy. So, but nevertheless, the official answer would be platinum-based chemotherapy.
Yeah.
Okay, there are couple of questions from our dear colleague, Dr. Maher, Dr. Niels. And the first one is, can you go with COVID-19 vaccination while the patient is receiving immunotherapy?
Absolutely, yes. We recommend it, and we participate in several trials with also immunotherapy, and all those trials also recommend COVID vaccination in parallel with immunotherapy.
Even with chemotherapy also?
Okay.
Yes and no. It's not the same because chemotherapy is a little bit immunosuppressive, and therefore we would wait until the cycle has been finished and maybe delay the subsequent cycle for, let's say, a week or so, because we may fear that it's less effective, the vaccination. It's not harming, it's rather less effective. And if possible, we do the vaccination before we start chemotherapy. But so far in Germany, we're a little bit behind. So far, we don't have the choice. We need to wait. Once we get an offer for our patient for vaccination, we will take it, and we will probably pause the chemotherapy for at least, let's say, a week or so.
Whatsoever the type of vaccination?
Regardless of the type of vaccination.
Yes, yes.
Dr. Maher again is asking you, Dr. Niels, if you ever use liquid biopsy, and if you do, at what circumstances?
We do use liquid biopsy for those patients where we cannot have a good tissue result. We can do only molecular testing. We cannot do PD-1 testing for liquids. That's important to know. And because the methodology is a little bit more difficult, we see about, let's say, 20, 25 of patients, of samples, we don't get a result back. And the problem is, if we don't find a molecular alteration in the liquid biopsy, we don't know whether the biopsy is negative or the test didn't work. And therefore, we need to repeat it. And it's just expensive. And therefore, we try to do a tissue biopsy, a decent one, and get the tissue testing and the PD-1 testing done with the tissue biopsy. And if that's not possible, we do a liquid. Some physicians say, well, we should do it in parallel. Of course, I would like to do it in parallel as well, but we couldn't afford it. We don't get refunded for both.
Okay, for patients who present with the so-called high symptoms or high disease burden, do you think that those patients should go for the combination IO plus chemotherapy or not really?
Yes, I think that is a subgroup of patients which probably benefit from the combination with chemotherapy. The studies didn't differentiate with 4 cycles or 2 cycles. We do know from the 9LA study that maybe 2 cycles of chemotherapy may be enough for checkpoint inhibitor combination of therapy. But for the high expressors, we would probably start with chemotherapy and immunotherapy. And if the tumor shrinks very nicely, we may think of ending the chemotherapy a little bit earlier than after 4 cycles. But this is off study.
Okay, and regarding the patient you presented to us with that excellent presentation, how long are you planning to continue with immunotherapy?
Good question again, because we don't know that either. This patient is still receiving in a trial, in the Impower 110 trial. Now it's this patient is being transferred to another trial. Well, we talked to the patient. There's no data of the need of continuation of immunotherapy. But the patient argues differently. He says, well, I am receiving a therapy which works very nicely. It's tolerable very much. I'm living a normal life. I am not impaired by this therapy. Why should I stop? And this is fair to say.
Financial toxicity. This is a problem.
Yes, as soon as this patient may experience toxicity, we will stop the treatment for this patient in this situation. Because I mean, we have 3.5 years of treatment now. But so far, he has no toxicity.
Okay.
Hey, one more question before we go ahead. If you have already decided that this patient will go for immunotherapy, Dr. Niels, do you have a preference to one IO over the other? Or there is a certain criteria that you follow to choose between immunotherapy checkpoint inhibitors?
This is Roche meeting.
Yes,
Yeah,
of course. But nevertheless, I mean, so far only pembrolizumab is being approved, but again, this will change very, very rapidly. It's difficult to say. There is no direct comparison. There is a meta-analysis comparing PD-1 and PD-L1 inhibitors, and they demonstrate that it's nearly the same, the toxicity. Some less pneumonitis being reported for PD-1 checkpoint inhibitors, such as atezolizumab. So this may be an advantage for atezolizumab.
Can I ask a question? So, what is your preference after progression in a patient with EGFR mutation after TKI?
I come to that a little bit later.
All right.
Because this is a question of, there's only one trial which investigated this scenario, and I come to this trial in my next segment.
Okay.
Okay. Actually, in that case, we would kindly ask you to go ahead, Dr. Niels, and we are enjoying very much your presentations. Go ahead, please.
Wonderful. So I hope you see my slide. So what about those patients which have no high expression of PD-L1, who have made, let's say, intermediate or zero PD-L1 expression? And these patients have been investigated with the combination of chemotherapy plus IO, or I would rather say immunotherapy plus chemotherapy, in comparison with chemotherapy. And all those trials again have demonstrated improvement of median overall survival if we combine immunotherapy with chemotherapy. So the Keynote 189 study investigated pembrolizumab plus chemotherapy versus chemotherapy alone, significant improvement. The Keynote 407 study did again pembrolizumab plus chemotherapy versus chemotherapy only in squamous non-small cell lung cancer. Again, significant improvement independently from PD-L1 expression. And also the Impower 150 study. This study actually is a little bit more complicated because they also used bevacizumab in combination with atezolizumab and chemotherapy in comparison to chemotherapy plus bevacizumab. So we can see again here from those three trials that the comparator is different for those three trials. Only chemotherapy plus bevacizumab was used in the Impower 150 study, and you can see that the median overall survival of the comparator arm is better in comparison to the Keynote 189 study, 14.7 versus 10.7 months. So let's say the Keynote 189 study was the first trial in this regard, demonstrating significant overall survival improvement, progression-free survival, and also response rate. And this also was a landmark study setting the new standard chemotherapy plus IO as first-line treatment, regardless of PD-L1 expression. So we have a different option. We already discussed about it. For those with high expression, we can use either immunotherapy without chemotherapy or immunotherapy with chemotherapy. For all other patients, the new standard is immunotherapy plus chemotherapy. The Keynote 407 study, again, pembrolizumab plus chemotherapy, now with metastatic squamous non-small cell lung cancer. Combination was paclitaxel or nab-paclitaxel and platinum-based. And you can see here that, again, significant improvement with pembrolizumab plus chemotherapy. And this was seen predominantly, of course, in those with positive PD-L1 expression, but for those with less than 1% of PD-L1 expression, there was also some improvement. But of course, this study was not powered to demonstrate differences in this subgroup here. So the Impower 150 study was a little bit more complex because they had three arms. Arm A was atezolizumab plus carboplatin paclitaxel. Arm C was carboplatin paclitaxel plus bevacizumab, the Sandler scheme, demonstrating superiority of chemotherapy only in that trial. And then the arm B was combining atezolizumab plus bevacizumab plus carboplatin and paclitaxel. The rationale is that bevacizumab is an anti-angiogenic antibody, anti-VEGF, but indeed VEGF also has several immunomodulating aspects, and therefore the combination of anti-PD-L1 and anti-VEGF makes sense because it may enhance immunotherapy, at least in preclinical trials. So this was the final analysis. Overall survival in the 4 drugs regimen versus chemotherapy plus bevacizumab, demonstrating significant improvement of overall survival in all patients with wild type here, no EGFR, no ALK here in this population. But I have to go one slide back again. We need to keep in mind that this trial was also recruiting patients with either EGFR or ALK positive findings after TKI treatment. But nevertheless, this was the wild type group, similar to the Keynote 189 study. They also looked only at wild-type patients. And this trial here demonstrating significant improvement of adding atezolizumab to chemotherapy plus bevacizumab. In the low expressors, there was no significant difference, but again, this trial was not powered to find differences here. And those with positive PD-L1 expression, either low, intermediate, or high expression, again, significant improvement, even higher than the all-comers here. Progression-free survival was also significantly improved with the 4 drugs regimen in comparison to chemotherapy plus bevacizumab, hazard ratio of 0.617. And again, here, this is important. There is some patients, subset of patients with long-term benefit with the combination with atezolizumab. Most importantly, because we know from the ECOG 4599 study, this was the trial which investigated bevacizumab in combination with carboplatin and paclitaxel. And this trial found, in particular, patients with liver metastasis, a clinical benefit of adding bevacizumab. And now here with the Impower 150 trial, looking for combination of atezolizumab plus bevacizumab and chemotherapy versus chemotherapy plus bevacizumab alone. Patient with liver metastasis have remarkably improvement of overall survival. And this difference was not seen in the comparison of atezolizumab plus chemotherapy without bevacizumab, or chemotherapy plus bevacizumab without atezolizumab. So here, the 4 drugs regimen really marks the difference. And those patients without liver metastasis, there was no clear difference. Also, response rate and duration of response of patients with or without liver metastasis were remarkably improved. Here on the left-hand side, patients with liver metastasis, in blue, the 4 drugs regimen significantly improved, and also the duration of response significantly improved in comparison to all other study arms. What about safety? Again, here we see that there are some immune-related adverse events, but the additional toxicity of atezolizumab plus chemotherapy plus bevacizumab was not remarkably enhanced, and therefore, again, this is a very tolerable treatment regime. And of course, we need to take care of immune-related adverse events like rash, hepatitis, and so on and so on. But again, most patients had low-grade symptoms, easy to handle, but we need to know them. That is important, because if you know and find some patients with some side effect in grade 1 or grade 2 severity, we need to act according to various guidelines and recommendations, also by the company. And then this grade is easy to handle the side effect, and it's not going to grade 3 or grade 4. This is here arm B, atezolizumab plus bevacizumab and chemotherapy. Again, no major difference, and the arm C had no immunocell therapy. Regardless, some patients did experience some side effects which looked like immune-related adverse events. And then there's some specialty of the Impower 150 trial, because this is the only trial which did allow the inclusion of EGFR and ALK-positive patients after TKI treatment. Regarding to ALK, there's no data available, because nearly no patients were included with ALK-positive and after ALK TKI treatment, so there's no data from there. But for EGFR, there is data, because some patients had TKI treatment first and then were recruited to this trial. And also in this subset, the combination of atezolizumab, bevacizumab, and carboplatin paclitaxel did result in an improvement of overall survival. And then there's publication on this, and here again in the ALK in the EGFR positive patients, 124 patients, the 4 drugs regimen, they had a significant improvement, not so significant, an improvement of overall survival, median overall survival in comparison to chemotherapy plus bevacizumab, which was also good with 18.7 months, but here the median overall survival was not estimable, and therefore it's ongoing. But most importantly, for those patients with sensitizing EGFR mutations, which means either exon 19 or exon 21 L858R alterations. Here, the significance, the difference was even more pronounced. Median overall survival, again, not estimable, but here the hazard ratio was 0.31, so significantly improved. So that means obviously some patients were also recruited in the Impower 150 trial with non-typical EGFR mutations, and there we know that this is a different biology. But nevertheless, we have now an option for EGFR positive patients after completion of TKI treatment with the combination of immunotherapy plus chemotherapy. And that is actually something which we use in our clinics as well, because we do know that immunotherapy as monotherapy is not as efficacious in EGFR positive patients as in wild-type patients. And therefore, I think the best chance for a patient to benefit from immunotherapy is in the combination with chemotherapy and bevacizumab. It's also the only approved drug regimen in this setting. But interestingly, other studies are investigating this situation, and we will see what the data comes out. But so far, only this regimen of atezolizumab, bevacizumab, and chemotherapy is approved for treatment of EGFR positive patients after TKI treatment. So back to the safety. The safety was similar across all trials. The discontinuation was, of course, a little bit different from the immunotherapy arm in comparison to the chemotherapy-only arm, because there was an ongoing treatment with the checkpoint inhibitor. But nevertheless, all those trials resulted in a very tolerable treatment for ECOG 0 and 1. So now we have several treatment options for treatment-naive non-small cell lung cancer. First of all, of course, molecular testing. Then for patients with high expression of PD-L1, we can use either pembrolizumab or atezolizumab. And in the combination with chemotherapy, we have several trials looking for the combination of checkpoint inhibitors with chemotherapy and or bevacizumab. And this drug regimen, these drug regimens can be used regardless of the PD-L1 expression status. So it's getting more complex, but the most important figure is always, what about the patients with long-term benefit? And this is something which will be explored in future trials as well. So of course, we would like to have more predictive factors. We have only so far PD-L1. At least we have this easy accessible factor. But of course, it's much more complex. The situation of the immune cell status in the patient may be different, called from immune desert to inflamed stroma, immune excluded, or inflamed infiltrated. This is the status where PD-1 or PD-1 checkpoint inhibitors might work best. But it's even more complex if we include genetics, age, microbiome, and so on and so on. So we would need definitely more predictive factors to look which regimen is superior to another in the light of a certain immunogram, as we call it. Nevertheless, the NCCN guidelines here now looking for PD-L1 expression above 1% have also adopted that here chemotherapy plus bevacizumab and atezolizumab is a recommended option in treating adenocarcinoma or large cell non-small cell lung cancer. So with this, I would like to thank you for your attention, and I will be happy to address questions before we move to small cell lung cancer.
دكتور عبد السلام اتفضل حضرتك.
Yeah, I think you already addressed everything. I really thank you. All right.
In that case, can we proceed?
Yeah.
Okay. Can we go to the small cell lung cancer, please, sir?
All right.
Okay.
So I have to first end the presentation and go for the next one. There we go. So last topic will be small cell lung cancer, extensive stage, first line. This is a subset of lung cancer which was not really seeing any substantial progress in the last 30 years. There were several trials looking for improvement of therapy options in small cell lung cancer. Very aggressive disease, very short survival, despite of a very big success of chemotherapy in first line, but very rapid progression, regardless of good response of first line treatment, and then in the majority, very short and rapid deterioration of patients. So there were several attempts, but none really succeeded, except Impower 133. We do know that in general, small cell lung cancer should be an immunogenic tumor. It has a very high tumor mutational burden. We do know that because most patients are heavy smokers. There is several data that there is suppressed but a persisting immune response in small cell lung cancer. We do know that the tumor infiltrating immune cell populations in small cell might be a little bit more sparse, but there is some prognostic importance, as demonstrated on the right-hand side. And of course, we do know that chemotherapy modulates the immunogenicity of tumor cells. So the question is, why not combining chemotherapy plus checkpoint inhibitors? So the Impower 133 study was here the landmark study who set the field: chemotherapy, carboplatin, etoposide plus atezolizumab versus chemotherapy alone. And also here followed by the maintenance with atezolizumab only versus placebo. And overall survival was the primary endpoint. Here, PCI was allowed per local standard of care. This is a little bit different to other trials which did not allow PCI in the study arm. But the Impower 133 study did allow that. And only 4 cycles of chemotherapy. So the characteristics like age, race, and so on were distributed equally between both arms. The smoking status was very fairly balanced. And you can see here also the blood-based tumor mutational burden, which was heavily discussed at that time as a potential predictive marker, was also fairly balanced. Liver metastasis, brain metastasis at enrollment was also rather similar. This is the updated overall survival, demonstrating for the first time after, let's say, 30 years, an improvement and significant improvement of overall survival in comparison to chemotherapy alone. It's not the same difference as in non-small cell lung cancer, but nevertheless, this is the first improvement after 30 years. The hazard ratio is 0.76, statistically significant, median follow-up 22.9 months. And also looking here at 18 months overall survival, more than a third of increase of 34.0% versus 21%. And the subgroup analysis was quite interesting because, first of all, it demonstrated equal efficacy regardless of sex. I would say even age. I'm not sure about this difference here in less than 65 years of age. It's being discussed that these patients may also benefit from cisplatin or would need more chemotherapy, but it's being debated. Nobody really knows the reason, but I don't think that a regimen which works that well in more than 65 years is less efficacious in less than 65 years. EEG performance status was no factor. Brain metastasis worked very well as well. Liver metastasis, and most importantly here, tumor mutational burden turned out to be no predictive factor in this study. This is the progression-free survival, again demonstrating significant improvement of progression-free survival with the addition of atezolizumab. Also response rate confirmed. Of course, we know that the response rate of chemotherapy is already very high, and there was no difference with the addition of atezolizumab. Of course, the median duration was somewhat longer with the addition of atezolizumab. And the patient with ongoing response, of course, 11 versus 3 at the time of data cutoff. This is what about patients with brain or with new brain lesions. We can see that less patients, regardless of PCI treatment, had new brain lesions with the addition of atezolizumab, and therefore this is a very efficacious treatment with patients despite brain metastasis as well. But again, this is difficult to address because this subject was not specifically addressed in this study, because only patients with PCI were allowed, with no brain metastasis was allowed, and PCI was possible. And therefore, we do not know whether patients with active brain metastasis may benefit to the same result, to the same extent. However, in our clinic, we use it similarly. That means we would do cranial radiation and would still treat with chemotherapy plus IO treatment. But again, this is not something which has been addressed in the study. In the study, it was only looked at patients without brain metastasis or stable brain metastasis. And this is, but since several trials had somewhat comparable situation and all indicated at least as efficacious as without the immune checkpoint inhibitor is therefore, I think the combination of IO plus chemotherapy would make sense in this population as well. But again, this topic is also being analyzed in current studies. Here, the time to intracranial progression, as I mentioned, was superior in the study arm, which would probably mean that patients with brain metastasis might benefit from this drug combination as well. But once more, this question has not been analyzed in Impower 133. What about PD-L1 expression? Well, in difference to non-small cell lung cancer, PD-L1 expression did not turn out to be a predictive marker in small cell cancer. I need to add that, first of all, only a subset of patients were amenable for PD-L1 expression. And we see that the cutoff here is 1%, which means that the majority of patients has no PD-L1 expression. And only some patients here, 72 and even less than more than 5%, have some weak PD-L1 expression. So PD-L1 expression is a different story in small cell lung cancer. Nevertheless, it did not turn out to be a predictive marker, and therefore we don't test for PD-L1 expression in small cell lung cancer. Safety, well, no new safety signals were observed. We do know the combination of chemotherapy plus atezolizumab from non-small cell lung cancer pretty well, and therefore no new findings were seen in the Impower 133 study. Adverse events of special interest like rash, hepatitis, and so on are well known in the same picture. Very few patients with high-grade immune-related adverse events, and therefore very tolerable if the patient tolerates chemotherapy. As I already mentioned, there were other studies on checkpoint inhibitors in combination with chemotherapy, like the Caspian trial, looking at durvalumab and platinum. This trial allowed cisplatin as well, and also allowed 6 cycles in the comparison arm, only 4 cycles of chemotherapy plus durvalumab in the study arm. The findings were similar though. Overall survival was significantly improved, but we can see the curves are rather similar between Caspian and Impower 133 study. And the same picture is true for progression-free survival. There's also was a study with pembrolizumab. It did demonstrate numerical improvement of progression-free survival and overall survival, but due to the a little bit complex statistical plan, the PFS finding was significant, but the overall survival was not. And therefore, it's officially negative study. Conclusions: atezolizumab plus carboplatin and etoposide demonstrated an improvement in overall survival for first-line extensive stage small cell lung cancer. Median overall survival was 12.3 months, hazard ratio of 0.76, and the 18-month landmark overall survival was also substantially increased. The exploratory biomarker analysis did not reveal any predictive marker, and that means any patient, regardless of the biomarker status, might benefit from this treatment. This is also, of course, a problem for us because we cannot distinguish patients which might benefit more from others. So that means we need to treat every patient in order to find those which the most benefit. So again, these results support the addition of atezolizumab to chemotherapy as the new standard of care for untreated extensive stage small cell lung cancer in an all-comer patient population. And again, the NCCN guidelines also adapted that the combination with chemotherapy plus IO is here in extensive stage. This is limited stage. Extensive stage is the preferred regimen of treatment for those patients. With that, thank you very much again for the very kind invitation and your attention. And once more, I'm happy to address any questions.
Okay, thank you very much, Professor Niels. I have a question from the audience, actually. This is from Dr. Ziad. He's asking, in case of TCI and ICI1, what is the best option?
For small cell or non-small cell?
Well, I mean, he didn't specify, but I mean,
I guess it's for
non-small cell lung cancer, yeah.
I guess it's non-small cell. Well, I would say chemotherapy plus IO, and there we have several options. We have the pembrolizumab plus chemotherapy trials. We have the Impower 150 trial, which is also looking for non-squamous histology, and therefore we can use either of those. It's very difficult to compare those trials because the comparators were different and the results were therefore different and the hazard ratios were different, but that is because the comparators were different. Of course,
this is another.
indicates that there's a maintenance treatment with bevacizumab plus atezolizumab. In the pembrolizumab trials, it's only pembrolizumab plus chemotherapy, let's say.
Okay, it's another one from Dr. Maher, and he's asking: is chemotherapy, immune checkpoint inhibitors, is of use in patients with, I mean, he would say poor general condition. I mean, I would say something like not a very good performance status. What do you see?
Good question. There's no study who really investigated ECOG-2 or 3 status. I would be reluctant of treating a combination with immunotherapy plus chemotherapy in ECOG-3. In ECOG-2, it depends, is it because of the tumor burden or is it because of comorbidities and age and frailty? If it's frailty and comorbidities, I may consider of reducing the dosage of chemotherapy and still adding immunotherapy for non-small cell lung cancer. For small cell lung cancer, there's just no data at all. It's a difficult question because we're really offline here, off-label. For those patients with a high expression of PIL1, I would definitely go for immunotherapy as monotherapy.
I mean, that was very informative. And Professor Abdeslam, would you like to add anything and conclude, please?
No, thank you so much. But I think we still have Dr. Walid. We still have Dr. Walid who will present a case for discussion. Dr. Walid. I think we have Dr. Walid who will present a case for discussion.
I want to thank Dr. Abdeslam and Dr. Ala for having this opportunity to discuss with you this case. I have enjoyed the talk of Dr. Nell. It was a comprehensive presentation about the IO in lung cancer. I really enjoyed it. A long time we haven't seen such a perfect presentation from Dr. Neil. This is my case. It's she is. Can you move it? I have so she's a 48 years old lady. She's a smoker, and she has some comorbidity. She has diabetes. She done a bariatric surgery. She has a family history of breast cancer from grandmother and from the father side HCC. Her performance status is from 0 to 1. She presented with dyspnea, cough, and especially in effort. Her initial presentation was in June 2020, where she had a PET CT where there is a left pleural thickening and left pleural effusion that has a high SUV. Biopsy was taken and from the left pleural thickening, and the diagnosis was positive for effusion. From the pleural thickening was adenocarcinoma as by immunohistochemistry. Patient underwent a panel of lung profile. There is no targetable or actionable marker for this lady, and the diagnosis was adenocarcinoma metastatic. Then, next slide, please. What is the treatment option for this lady? what do you think, guys? You can choose either chemotherapy alone, or you can choose immunotherapy alone. Can you choose immunotherapy alone, or a combination of immunotherapy? And if you combine, do you use a Keynote 189, or you choose the Impower 150? For me, because the patient has a PD-L1 negative, heavy smoker, the tumor burden was a little bit high. I haven't shown that. And I thought of trying to combine targeting, as Dr. Neil mentioned, the microenvironment as well as the tumor itself. So I choose to use the Impower 150. And I used atezo plus beva plus Taxol plus platinum. And as I mentioned, in June 2020, the pleural effusion was positive and SUV high. Patient received 4 cycles of atezo, beva, Taxol, carboplatin. And at the reassessment of September 2020, there is a reduction of the SUV by almost 30%. There is a clearance of the pleural effusion, and the right lung show no more nodules. And the conclusion was partial response. Patient of absence of dyspnea. By the way, this patient from Cairo, so she traveled nicely from Cairo to Alexandria to receive her treatment and go back. And at the beginning, she has a frustration and she was tired, but in the last 2 sessions, she done very well. Then we put patient on atezo plus beva because she was annoyed from her hair loss. So we put her, we stop at 4 cycles of chemo, and we start atezo beva beva Avastin. And in December 2020, PET-CT showing a stationary course. Patient continue on another cycle of atezo beva with well tolerated, but she started complaining of symptoms of hypothyroidism. She fell asleep more often. She get tired easily. She get fatigue. Her eyes start to her eyebrows start to showing buffness. I order and the TSH was high, and the T3 and T4 was low. So we stopped the treatment at that point. So this is a question, and my answer was withhold immunotherapy and initiate thyroid replacement hormone treatment. At that time, I gave her Eltroxin, and she started to improve immediately. I checked her after 1 week, she done well. Symptoms became less. She used to have a grade 3, became grade 1 in 2 weeks or 3 weeks. So this is, as Dr. Nell mentioned in his slides, how to treat immune-related endocrinopathy. Usually, when we saw from Impower 150 and others trials of using immunotherapy, you can have thyroiditis, which can lead to either hypothyroidism or hyperthyroidism. And if you have a hypothyroidism, as our young lady, usually we give, please go back. We give a hormone replacement. We give Eltroxin we check the TSH and the clinical evaluation every week. And if there is an improvement and the symptoms has disappeared and the TSH level are decreasing, you can start the treatment. However, if you permanently showing no improvement, you discontinue the T-centric permanently. And the same apply for hyperthyroidism exactly. And the patient start receiving blood symptom has she's doing fine, and she's supposed to receive her other cycle within this week. Thank you for listening, and I thank you for allowing me to share my case with you, and I'm happy to receive your question.
Thank you, Dr. Walid. It is very nice, and I think we are almost 2 hours presentation. So by this, I have to thank Roche for arranging this very nice meeting, and I really appreciated to Dr. Neil for his presentation with us today. And I am so glad that he gave us his very deep and rich experience in immunotherapy in lung cancer. Thank you, Dr. Neil, again. And I would like to thank my colleague, Dr. Gamal Hosseini and Dr. Walid Arafat for sharing us this session. And also, I have to thank the attendee from United States, from Kenya, from Tanzania, who are attending with us today. And it is really appreciating that we have very good attendee from many places in the world. By this, I thank you again, and I thank Roche for arranging the meeting.
Thank you very much.
Thank you, Dr. Neil, so much, and thank you, Professor Abdessalem and Professor Alaa for moderating also the session, and Professor Abdessalem for being our honorable chairperson, and Professor Gamal Hosseini for the excellent presentation, and Professor Walid for sharing this very nice clinical experience with us. And I would like, of course, to thank Dr. Neil so much for joining us on the Easter. And have a nice weekend, Dr. Neil. Thank you all. And thanks, of course, to the attendance.
Happy
Thank
Easter.
you to all of you. Thank you very much.
Easter.